everyone, welcome in the RKD community. Welcome to Nephcure's follow-up conversation to our first annual APOL1 Town Hall that happened early this year in April. We're excited to add this town hall to a great cause to not only spread awareness, but educate all those that joined the first one on some not only updated findings, but also different perspectives. We have with us some new faces and some that are familiar. Our great board member, Reverend Miles, will be speaking of Enon Tabernacle, which is a great partner in Nephcure. We'll have Dr. Crenshaw, who is an amazing and groundbreaking and celebrated doctor in the world of RKD, and especially APOL1, and also, as it happens, health equity. We also have a great genetic counselor by the name of Barbara Harrison, who is new to our network, but we're going to be calling on all the time and annoying, so hopefully she doesn't leave us. And also a very familiar face, a patient, an amazing advocate, and successful in his own right, Jordan Albright, who will be giving a presentation in regards to his experience with APOL1 as well as health equity. So tonight's lineup will go as such. I'll start out. My name is Montrez Lucas. I'm currently the Associate Director of Patient Navigation here at Nephcure. And we'll start out with Reverend Miles, who will be our Master of Ceremony. And then we'll head into the presentations of each others. And then at the last 10 minutes, we'll go into a question and answer period where you can pose questions in our chat. And our staff, we're almost like staff, aren't we? We worked together the last 2 days at the Congressional Black Caucus. Our panelists will go into answer those questions that you pose in the question and answer portion for the last 10 minutes. So gear up, buckle up. I'm excited to first introduce Reverend Miles, an amazing board member and leader in health equity, and one of the leaders of the amazing Enon Tabernacle. Welcome, Reverend Miles.
Well, thank you. So great to be here with you. And you're right, it has been a full day as we are at the Congressional Black Caucus advocating in this space, and super excited, as I said. So I am a staff pastor at Enon Tabernacle Baptist Church in Philadelphia, and I'll serve as your moderator for this panel. And what we bring to this conversation is creativity in the genetic testing and the screening realm. We encountered Nephcure several years ago, and they came, and what encouraged me to work with them, why I was encouraged to work with them, is because they were willing to go upstream. I'm frustrated like many of you, and I shared every opportunity I get with the number of dialysis centers in our community and the number of persons of color that I know who are on transplant lists as it relates to kidney disease. And so happy to be here with you, certainly looking forward to having an engaging conversation. And next slide. And just sharing, I don't want to be redundant, but just really want to drill down on who Nephcure is and why they do what they do and what makes them so special. And you can see the mission statement here is a patient advocacy organization. And that is so true. As we go throughout the evening, you'll hear more and more about the advocacy work and collaboration. And it goes on and it talks about empowering people with rare protein spilling kidney disease. Again, testing, a conversation. And we thank Dr. Crenshaw on the front end. Next slide, please. Who we serve. And, as we had this panel earlier today, I said, you know what, we won't even go into a lot of the definitions, but again, understanding it's the protein spilling kidney disease, and we're going to lean in on our professionals. We have two subject matter experts and again, a patient advocate to come alongside. So next slide, please. How we serve. And this is, again, what attracted me to Nephcure in the very first place. So it is around diagnosis, which is so key, and then providing care in a very creative way, understanding, because we're doing screening, and it's my prayer and my expectation that every patient, when they go to see their primary, that they would have a urinalysis and have their urine checked for protein, which is the lower protein. And then lastly, they're in the business of saving kidneys. Often in kidney disease, it sneaks up on us. Again, it's not, we know that we call heart disease the silent killer, but usually by the time we're dealing with kidneys, it's because we're pretty far down the road. So next slide, please. And this is how we serve, again, collaboration. And I think that's, again, what makes Nephcure so special. Not only are they on the tip of the spear in terms of research, working with clinicians, always having their fingers on the pulse of what's going on in the industry, advocating and lobbying as it relates to governmental affairs, but all while doing this all while patient focused. So again, we appreciate Nephcure. Next slide, please. And I said it earlier, I'll say it again. At times, I feel like a corpse at a funeral. And what do I mean by that? You expect me to be here, and I will be here for the duration of this panel, but you don't want to hear much from me. And so again, we appreciate the experts, we appreciate the subject matter experts. And so it's with pleasure and honor that I introduce to you Daryl Crenshaw. He's a native of Selma, Alabama, board certified internal medicine and nephrology. You can see the degrees for yourself, but he's extremely credentialed and has taken the time at every level to get the type of education that's needed to do the work that he's doing. In his current role as a practicing nephrologist in Thomasville, Georgia, the first African-American chief of staff, will honor him there at the John Archbishop Memorial Hospital and chair of hospital board of trustees. So important. Serves in dual roles, not only as a practitioner, but also as an educator, shaping minds and progressing. And then lastly, those two pieces, an advocate as well as a researcher. Loves God, understands community engagement and how to be effective. The next voice you'll hear is that of Dr. Crenshaw. Thank you.
Welcome, Dr. Crenshaw. Also, Reverend Miles, I'm not gonna lie. When we were at the Congressional Black Caucus this afternoon, and you said that analogy about being a corpse, I was scared. I was like, "Where are we going?" But you tied in really well. Dr. Crenshaw, welcome.
Thank you, Dr. Miles. Thank you, Montrez, and good evening, everyone. For the next few moments, I would like to talk about this unfortunate yet unequal burden of kidney disease on Black Americans in this country. Next slide. And so for our agenda tonight, we'd like to overview kidney disease, reviewing the clinical impact of kidney disease, discussing the psychological effects, along with the economic impact and the genetic risk factors for kidney disease in Blacks in the United States. I also like to discuss the importance of genetic testing, and then lastly, discuss goals for screening and awareness for Blacks in kidney disease. Next slide. And so when we look at the overview of kidney disease, we recognize, unfortunately, that chronic kidney disease is a nationwide epidemic affecting 1 in 7 individuals in the United States. That's roughly about 40 million individuals in this country. And also, unfortunately, Black Americans account for 32% of kidney failure in the US, and also are 4 times more likely to develop kidney failure than white Americans in this country. And so to put this in perspective, you have to understand that Blacks in this country only comprise about 13% of the US population. Yet 35% of all dialysis patients that are present are people of color. And so we see this tremendous disproportion of African Americans of kidney disease in this country. Now, when we look at the clinical impact of kidney disease in Blacks, we recognize that hypertension and diabetes make up the majority of kidney disease in Blacks in this country. But bear in mind that there are other causes of chronic kidney disease in Blacks as well, including lupus, glomerular disease, one in particular known as focal segmental glomerular sclerosis. This is the most common glomerular disease in Blacks, But now we're paying more close attention to genetic causes of kidney disease, including polycystic kidney disease and a very unique disease that we're going to discuss momentarily known as APOL1 mediated kidney disease. Now, these two charts right here, I'd like to highlight briefly. Number one, you can see to the left, this stage of chronic kidney disease. I want everyone to be aware of this, to understand that there are 5 different stages of kidney disease. Stage 1 is when the kidney functions is essentially normal. Stage 2, this is when there is mild loss of kidney disease. Stage 3, this is when individuals should be under the care of a certified nephrologist. This is when you start seeing mild to moderate kidney dysfunction. Stage 4, this is when the kidney function is very severe. And unfortunately, when you reach stage 5, this is when an individual is classified as end-stage kidney disease. These are the individuals that have kidney function less than 15%. So the slide to the right, showing the warning signs of kidney failure. I just want everyone just to kind of know some of the typical warning signs. This includes extreme fatigue, nausea and vomiting. Sometimes people can have confusion or trouble having levels of concentration appropriately. You can also see swelling, particularly in the hands and ankles. And then lastly, you can also get a poor appetite and have a metallic taste. These are some of the general signs of early kidney failure. Next slide. I like to highlight this slide because this slide shows the CKD or chronic kidney disease diagnostic inequity that's impacted by states. And so if you can look here at the southern part of the United States, highlighted in the lighter colors, you can see here that these individuals have a significant amount of diagnostic inequity. What that means is that chronic kidney disease is underdiagnosed, particularly in people of color in the US. And unfortunately, in these same states, we see that they have a higher risk, up to a 14% higher risk of kidney disease in the southeastern part of the United States. Also, you can see here that the lighter colors are actually trending up even towards more the northeastern part, even as far as the Virginia, DC, and Maryland area, where you're truly seeing this diagnostic inequity. Next slide. And as a consequence of this diagnostic inequity, unfortunately, we see a similar burden of high death rate from kidney disease. And so tremendous recognition needs to be played here because we recognize that with this significant amount of high death rate, truly validating that there's a CKD diagnostic inequity around the country, and particularly in the southeastern part of the United States. Next slide. I like to highlight here some of the psychological impact of kidney disease. We understand that there was a study that revealed within 1,000 patients who had kidney disease, 67% of this 1,000 experienced symptoms of depression. 36% could not take care of themselves due to mental health problems. An additional 27% contemplated self-harm or suicide. Up to 68% were not offered mental health support. Again, showing this diagnostic and healthcare inequity that we see in our country. And an additional 53% admitting and finding it hard to speak up about their mental health. I want to highlight this because as a practicing nephrologist, I see similar numbers in my patient population. Many of these patients are depressed. Unfortunately, many of them cannot take care of themselves. About a quarter of them definitely have self-harm and contemplate suicide. Again, showing the psychological impact when it comes to kidney disease. Next slide. But I'd like to highlight here in a brief moment an introduction to a new way and a way we can actually diagnose and treat kidney disease, particularly in African Americans in this country. Take a look at this slide.
We don't hear the audio.
Okay. If we can't hear the audio, I'd like to go ahead and summarize this. What we're revealing now is that due to this diagnostic inequity and recognition that for the last half century, this disproportionate number of African Americans being on dialysis, it was always recognized that this was attributed to diabetes and hypertension alone. What we have come to find out now is that there literally is a third cog in this wheel, and that cog is known as APOL1. For those who don't know, APOL1 is a very common gene that every individual in this world has. We all have 2 copies. We have 1 copy from our mother and 1 copy from our father. But what's unique, and particularly in individuals who reside in sub-Saharan Africa, this gene actually, in its mutated form, has a very unique benefit in protecting a trypanosome called African sleep sickness in sub-Saharan Africa. And meanwhile, once this gene is mutated and has these what we call high-risk allele variations, when that gene gets over into the Western world and due to other environmental factors, there is this risk for developing APOL1 mediated kidney disease as a result. And so there's a 20% chance that if you have two high-risk allele involvement, there's a relationship that you can develop chronic kidney disease. The reason why this is important is because people of color who have been misattributed to having hypertension as a cause of their kidney disease, now we recognize that realistically, the major factor now may be APOL1 mediated kidney disease. And so what has happened now is that we have the test to be able to test for this actual gene variation. And it involves a swab of the cheek. But we can also test, as you can see here, by looking for protein in the urine. We can also look for a rise in the serum creatinine. We can also look for clinical presence of kidney disease. And we can also get an abnormal kidney ultrasound to validate if someone qualifies to be tested for APOL1 mediated kidney disease. And so when we test for APOL1, we check the urine, particularly for protein. And we also do an oral swab for APOL1 testing, and we can also get blood data to further validate if an individual is at high risk for developing kidney disease from APOL1 mediated kidney disease. Next slide. And so I'd like to close this talk with the understanding that it indeed takes a village to take care and mitigate the spread of kidney disease in this country, particularly amongst African Americans. One of my biggest passions is doing community awareness and screening events, because I understand, as you're going to hear today, that it doesn't take just the practitioner or the physician, but it also requires men of God and leaders like Reverend Miles, and like you're going to hear next, and Barbara Harrison, who's an expert in genetics, and you're going to hear a phenomenal testimony from Mr. Jordan Albright. But it takes everyone involved for us to hopefully mitigate the spread of kidney disease and to reduce the unequal burden of kidney disease in this country. Thank you.
Excellent. And thank you. Thank you again, Dr. Crenshaw. Two things as you were speaking that jumped out at me. Number one, we're beginning to understand how kidney disease impacts us physiologically, but I'm also encouraged, as you shared, how it impacts us psychologically. And then secondarily, again, community screenings, you mentioned houses of faith, and yes, at church and synagogues and the mosque, we are beginning to have these necessary conversations. And as trusted messengers, we're getting the word out, education is happening, and trust is being built because of persons like yourself, Dr. Crenshaw, and relationships with community-based organizations. So again, we thank you. And we transition now to a fast friend. We share Pittsburgh, Pennsylvania together, Barbara Harrison. She is a DC native, but spent doing some of her graduate work again with a master's degree in genetic counseling from the University of Pennsylvania. In her current role, assistant professor of Howard University College of Medicine, assistant director of community outreach and education at the Howard University Center for Sickle Cell Disease. We appreciate her over 3 decades of work as a genetic counselor at the university, covering a wide range of indications. And again, we appreciate that she understands her role and is dedicated to advancing diversity and inclusion in genetic counseling, something that we don't talk enough about in our community. But because of who you are, we appreciate what you're going to share, and it does allow us to trust in ways in which we have not trusted in a mighty long time. So, Barbara Harrison, thank you.
All right, thank you so much. So welcome to everyone out there. And definitely thank you to Nephcure for welcoming me into the family. So I am excited to talk to you today about genetic counseling, a little about genetics, and also testing in APOL1 kidney disease, mediated kidney disease. Just very quickly, I always have to say I'm representing myself, not officially Howard University, although I've been at Howard for many, many years. And so this definitely has informed many of my views and my thoughts as I've talked to patients over the years. We can go to the next slide. So I'm sure some of you out there might be wondering what in the world is genetic counseling, because I always like to provide just some insight into that question. So essentially, genetic counselors are medical professionals, and we are specially trained in genetics and in all these new technologies um, that are becoming more and more a part of our everyday medical care. In addition, we have not only that technical knowledge, that scientific knowledge, but we also are trained to have particular sensitivity to the effects that this type of information can have on an individual and on a family. And so if you think about people with genetic conditions and even the things that Dr. Crenshaw spoke about specifically with kidney disease and some of those feelings of depression and mental health issues and kind of that impact that disease can have in general, that can be kind of have a ripple effect. You want to say it that way when you deal with genetic conditions, because often the information that is learned not only affects that person, but then has implications for other people in the family, and how they receive that information and kind of process that information can be variable, and can just be helpful to have someone around who, truly understands that and is empathetic to that. So genetic counselors do all the things I have here in these circles, including identifying treatments and management, providing answers to families about why certain conditions are happening. But I'm going to focus on those three kind of yellow outline circles today, including talking about finding a genetic testing laboratory to do the testing, connecting individuals to organizations like Nephcure, cascade testing, which is kind of the term we use when we talk about the fact that if someone has a particular gene, then there's, a likelihood that others in that same family share those genes and may benefit from testing as well. So if you go to the next slide, I'll kind of talk through these a little bit more. So one of the first steps, after kind of getting to know an individual when I'm meeting with them for genetic counseling, is to provide some education. And so I'm going to just do that very briefly here as we talk about this APOL1 gene. So as Dr. Crenshaw has already delineated for us, we obviously we get our genetic information from that egg and sperm. And for every gene that we have, we get one copy or one variation of that from that egg and one copy or variation of that from the sperm. And for every gene, there's going to be different variations of a gene. And I'll use an analogy of eye color. So if I simplified eye color and said that it was only due to one gene, then you could envision that there's a blue eye gene, there's a brown eye gene, there's a hazel eye gene, brown eye gene. And so those variations within that same eye color gene are fine. They're not causing a problem. They just lead to the beautiful diversity that we see amongst us, kind of amongst humankind. However, there are some variations of a gene that may be problematic or may be associated with the disease. And so if we come back now to APOL1, we can imagine that there are variations of this gene that are fine and don't cause a problem, but there are other variations of this gene that, if inherited, could cause a problem and lead to an increased risk of kidney disease. Now, specifically with this APOL1, you actually have to inherit one of those high risk, variations of that gene from both parents. So if you get it from that egg and you get it from the sperm, then that person has this increased risk for kidney disease. Now, what that also means is that all the full siblings of that individual also have a 25% chance to also have inherited those two high-risk variations of that gene. And so again, this type of testing not only affects that individual, but it also affects other people in the family. That means that their parents can have at least one copy of it, but other individuals may have two copies of it as well in the family. And so that's where we get to kind of this cascade testing, where we start thinking about, okay, we've identified this one person, who else in the family might also be at risk? And then when we start talking about, okay, let's say we identify those individuals, now what are those risks and benefits of having testing? We think about these in particular, if you have an individual who does not have kidney disease yet. So maybe they know that they have someone in their family who has an APOL1 related kidney disease, and now they're considering whether to get testing. Some of the benefits of that, obviously, are they could have more information that can empower themselves to take care of themselves better, to help their healthcare team take care of themselves, take care of that person better. But they may also have some hesitation. Some people will have a hesitation because they'll fear that they'll lose their health insurance, or it may have some negative impact in that realm. And the great news around that specific concern is that there is some legislative protections for individuals that are found to have an increased risk based on genetic information. There's a law that is called the Genetic Information Non-Discrimination Act, and it forbids health insurance companies to make decisions about whether or not to cover a person or to set their premiums based on this genetic risk information. So that's something that individuals may not be aware of. That's, a discussion that a genetic counselor can have with them. But there are other kind of social impacts of this type of testing that aren't covered. So if a person is getting life insurance or disability insurance, then this genetic information could be used to set those premiums and so forth. And so sometimes that's a conversation where people will delay testing until they get those insurances in order, or they just may not be in a headspace where they can accept this kind of information and really process it well. And so that can be all part of this informed decision-making process that a genetic counselor is really specifically trained to be able to have and help individuals work through. Now, if a person decides to go ahead and have testing, a big question is always, where do I get that test done? And there are, many genetic testing companies out there, some of which we as clinicians use more often versus ones that you could, look on the internet and send, a saliva sample to X company and they'll give you information back. And so there are pros, mostly pros who like to, of course, do that in the clinical space because we know that we'll get the most reliable information. But for some, in certain circumstances, people may decide they want to do that on their own and not go through a clinician and go through, again, something like on the internet. And sometimes that information can be good, but sometimes it's not. And so being able to have that conversation and work through those options as well can be benefit in the genetic counseling space. Now, something that genetic counselors always do is take family histories. This helps us to identify those other family members who may be at risk, and also help guide us as to maybe something else that might be going on in the family. I've come across, as I've learned more about APOL1, we've learned about some of the other effects that this might have on a person's health. There's some information out there that this may lead to an increased risk for something called preeclampsia and pregnancy. If a fetus as carrying these high risk alleles, and it may be multiplied if the mom is as well. And so, we know in our community, maternal mortality is an issue, and maybe this is something that's factoring into it. We don't know. And one of the exciting things, I think, is that as we get more attention to this gene, we'll get to learn more about it. We'll get some support around research so that we can learn more about what are the effects, not only within kidney disease, but more broadly, that might help us to answer some of these questions as to what has been going on in our community in terms of some of the health disparities and things that we're facing. So genetic counselor would, be able to know about those things and even pluck those types of things, not just who had kidney disease, but maybe who had problems in pregnancy, that type of thing. And then lastly, in this realm, genetic counselors help connect individuals to resources. And Nephcure is a phenomenal example of someone who I certainly would point a patient to for that long-term support, place that they could get the most current information and really provide a sense of community around it and help to remove some of the stigma that can go along with a person having a genetic condition and not wanting to talk about it, not wanting to divulge information to their family members. Sometimes it's just about removing that stigma, making people understand there are others in that same boat. And together we can get much further than, if they're trying to deal with those things alone. You can go to the next slide. So the unfortunate part, though, is that there's a limited number of genetic counselors. I think we're right around 7,000 now, which may sound like a lot, but we're kind of dispersed throughout the country, and we're really in, mostly in more urban areas around your big academic medical centers. And so it can be difficult for people to assess genetic counseling services. Some may depend on telemedicine services, and that's becoming a more available option. But one of the key problems around access is that there is some limited acknowledgement of genetic counselors as licensed medical providers. And this is something that, as genetic counselors, we've been dealing with state by state. We're slowly getting that legislation through where there's genetic counseling licensure in a little over half of the states, but not all states have that. In addition, Medicare and Medicaid do not formally recognize genetic counselors as providers, although they do recognize the service of genetic counseling and the importance of it when making genetic testing decisions. And so we're kind of helping bring them along. Like, if you're understanding what genetic counseling is, we need to get those genetic counselors actually recognized so that we can increase access, so that hospitals don't feel like they're just paying out to a genetic counselor that salary, but not being able to get reimbursement for those services, because that really does have a direct effect on access. And so I just like to end then with the next slide, which just talks about an active bill that's in Congress now, in the federal government, to change this story, to make genetic counselors, to rather to have CMS, or the Center of Medicaid and Medicare Services, formally recognize genetic counselors as providers. And being able to do this and be able to assist our physician colleagues, so they're not burdened with trying to have this conversation. We can have that conversation in a genetic counseling space, which may be a half hour, 40 minutes that I can sit with a patient and talk about this. And, whereas physicians often are pressured with a small amount of time to have to cover a lot of information, that we can be there to assist in those conversations. And so we are happy that organizations like the American Kidney Fund are certainly supportive of this legislation. And so if you're out there, if you're an advocate, please just throw in whatever 2 cents you can to help us out to get this over the finish line. But hopefully I've given you kind of an overview of what genetic counseling is. I am more than happy to answer any questions that folks may have. And so with that, I will turn it back over to Reverend Miles.
Thank you. Thank you. Barbara Harrison, we appreciate your expertise. You are what I guess we would call a unicorn, given the small number of persons in this country with your expertise. But thank you, because we're often talking about trusted messengers, and when persons like yourself do the work, and then you share the information, we tend to hear it differently than when shared by some of our other counterparts. And so for that, we thank you. And I thank you. One of the strengths of our work at the church is we look at health holistically. We're always talking about health, not just in a vacuum. And so, and we're focusing on maternal health. And as you're sharing some of the implications there, my mind was thinking of how we can infuse some of this conversation into conversations when we're talking about maternal health. So thank you again. And as you were speaking as well, and also Dr. Crenshaw, you both kind of reminded us that you're not alone, you're not alone, you're not alone, you're not alone. And so we appreciate Jordan Albright because he reminds us too, as he'll share his story and his journey with Nephcure as well as APOL1, that we're not alone. So Jordan Albright comes to us, and he joined in January of 2023. as a volunteer community leader in Atlanta. His background is extensive in networking relationships, relationship building from the film and entertainment industry, and his current role as an associate at Rise Property Group, a commercial real estate brokerage firm in Atlanta. We appreciate his journey and his story, which you will hear shortly. That since he's an inspired advocate after both he and his younger brother were diagnosed with APOL1 FSGS, a rare kidney disease, his brother's resilience motivated him to spread awareness and positivity. He again is an Atlanta native with roots from Northern California. He enjoys staying active, DIY projects, water and snow sports, traveling and gardening. Jordan, we thank you. Please share your story.
Thank you so much, Reverend Miles, Montrez, Barbara, Dr. Crenshaw for sharing again. And for everyone who does not know, I am Jordan Albright. I was diagnosed with APOL1 FSGS shortly after my younger brother Joshua a few years back. And my brother was actually at my aunt's house messing with the blood pressure machine, and it was throughout the roof. He had to be rushed to the hospital, kept overnight, and from that night on, the rest of our family would just basically have contracts, thinking that every little thing could potentially be leading to us having the same thing. So, of course, all of us went and got our general checkups with our doctors. If you go on the next slide, that'd be great. And yeah, that is when we began to, begin our journey within the kidney disease world. So, it was very off guard, very random. We were very lucky that we caught it when we did, because something we realized that it truly is a silent killer. We lived our whole entire lives without really realizing what it was happening to us before it was too late. And if you can go on to the next slide, that'd be great. After our diagnosis, a lot changed. I would say mostly within our diets. We were both kind of already trying to be a bit better about it, focusing on making sure we're eating right, getting our minds right, and just understanding that our physical health and everything internally is so important, but understanding that how our mental is so intertwined and connected, that if I lose one thing over the other, that I can ultimately lose both. And if I don't make sure I'm thinking right and making sure we're in a positive mindset, both myself, my brother, and my family, and keeping up in high spirits, that it would ultimately just make us be in a worse position as far as our health overall. So we had to really think about what was important to us, what we needed to focus on, our values, our priorities, and having our family structure was so important in supporting one another. And I don't know what I would have done without that situation in place, frankly. I have an amazing family from top to bottom. So really had to lean into each other throughout the whole process. And again, it's kind of deepening and understanding more of how we think about life, our perception of it, and just really fortifying our own mindset of, okay, this is what the situation is. This doesn't need to be a defining factor of our lives. If we just focus on the positive sides of things, we can really get through this with one another, and that's ultimately, what's so important as far as a family. And a few photos here at the bottom there. My brother, me shortly after my diagnosis, and the one far right of my brother at one of his last appointments where he found out he was diagnosed. So a lot of it was happening those few years. Next slide, please. To further piggyback off on the perspective of life just changing, just really having to think about, what we're going to continue to do as far as the next steps in our lives. We could dwell, sit in our emotions, and feel like, it's a death sentence because it was so brand new to us. We had no idea. We're very ignorant to what chronic kidney disease is, let alone APOL1 FSGS. We've been talking about genes and mutations, and it was a lot to take in at once. So we really had to take a step back and talk to one another and think to ourselves about how we're going to proceed throughout our lives. So we had to really, again, lean into one another, try to really focus on growing our own selves and understanding who we are as we go through this together. And yeah, so really changed a lot in those young ages. As far as my younger brother's only 21 now, but he's mature beyond his years. Next slide. And next part of our journey was getting involved in advocating pretty quickly. When my brother was diagnosed, he really, really, really just wanted to get a deeper understanding. He wanted to help spread awareness. It was very, very clear to him, myself, and our whole family that he virtually had no symptoms, neither myself. Of course, after diagnosis, you start thinking back and think everything may have been this or that, but in all reality, we're all human beings. We don't always feel great. But for us, getting involved in advocacy was very helpful for us to, one, kind of vent and talk about our stories, listen to other folks and see what they've been through, and understand that we're not alone. We're not the only people going through this, and there's plenty of organizations that have been doing this sort of work for a very long time that were already established. So my mother finding Nephcure through a Facebook page was a huge blessing for us because it opened up the door to so many resources and really helped us throughout our journey in life. So a few photos there just showing our different advocacy efforts throughout the years and kind of continue to do so. Just again, for it really just helps us to understand more, learn more, and continue to be in a community that helps us to grow and understand what it is we're all living with and what our loved ones may be as well. Because as we know, a lot of people just living every single day having no idea what it is, maybe question inside of them. Next slide, please. And for the future, I would say that I put a quote in the bottom right corner is that you don't need to see the full staircase. You just got to take that first step, see the first step, and kind of just keep on moving through. So I don't need to understand what's going to happen, all the way down the line. But as long as I'm taking the right steps in place and trying to understand and learn something new every single day, make sure I'm staying on the right track and just helping to continue to spread awareness and work this with my family. My thought process is the more we just do that and just do things that are true to us, it'll all come in fruition all together. So, and as far as just our lives for vision, just hope to continue to be healthy, continue to be in a good place because we've been very blessed as far as getting diagnosed and fortunately not being too far along because it was very scary. And I'm saying that we had, hearing chronic kidney disease, stage 2 of this, genetic mutation, it was very scary. So we had to really broaden our thought process for the future because for a long time we really had no idea what we thought. But I can happily say nowadays it's a lot brighter for us now. We're very happy for the future. We're very excited for it. And next slide. And that is it. I appreciate all y'all's time. I would say if anyone had any questions or thought processes on like proceeding forward and thought as to what would do next as far as a call to action, it could be something as small as talking to a friend, family, anyone that may be experiencing something like chronic kidney disease or any other disease like such. Because I talked to a friend and colleagues that actually they have walked in when I was just messing with my blood pressure machine, seeing what I live was right in the middle of my day, and they take it, try it, and they actually had elevated blood pressure, and ended up talking to their doctors and getting on like a plan as to how to maintain their health moving forward. So just having small conversations can lead to so much more large big results in someone's life. You never know who may be going through something. So again, thank you all so much, and that is all for me today. Thank you.
Thank you so much, Jordan. Thank you so much. Before we move forward, I mean, we'll close things up and wait to before we go into the question and answer period, I first want to say thank you to Jordan Albright once again for sharing his testimonial and his personal experience. Barbara Harrison for joining our Nephcure family. You're now a cousin and we're not going to leave you alone. And the great Reverend Miles for everything he has done to push Nephcure ahead, especially when it comes to community engagement and health equity and all the beautiful things that Enon does. Dr. Crenshaw as well for his amazing work at not only my alma mater, Florida State, but also in his whole career and everything he has done to push not only health equity, but also spread the word about APOL1 and how it affects Black Americans. Before we go to question and answer period, I also want to thank Vertex for sponsoring both of our APOL1 town halls, the one we had in April, as well as this one. Vertex has been a beloved partner of ours, and we really thank them for supporting us. And now we can take some questions. We will stop sharing and take some questions. You can put your questions in the chat. I have a question first, selfishly, Dr. Crenshaw. As someone who has done mental health for quite some time now, I'm very interested when you spoke about the psychological effects and impacts on those affected with kidney disease. I want to know what do you though you're not in mental health per se, when getting a newly diagnosed patient and you notice those signs of depression, what do you advise as far as what they should do next?
That's a very good question, Montrez, and it's a very important one. You know, thankfully, when a patient has severe kidney disease, the one thing I'm advising them, and I do it somewhat intuitively because I get involved, um, meaning my office and my staff, because we understand the psychological aspects. We use a kind of a varied approach. Number one, we have case management that has been very well versed in kidney disease and the psychological effects of kidney disease. Just given the tremendous burden and the endemic area that we reside in, virtually every one of our case managers understand that it goes beyond just the healthcare and the physiological and the pathological aspects of kidney disease. It goes over into the mental. So even from the hospital stay when they were diagnosed with kidney disease, as soon as they get home, they're plugged in to our social work team. They're plugged in. Actually, we have psychologists in our area that we have sent them to. We use a medicinal approach because we do use antidepressants, and we really encourage our patients to get treatment, particularly if they're severely depressed, and understand that mental illness in that regard, meaning depression, is not a bad thing. It's a very understandable thing, and the fact that it's very treatable with medicines. And then also too, we love to incorporate the community support. So we encourage our patients to get plugged in with pastoral leadership, get involved with the family. Again, the whole adage, it takes a village to take care of these patients. And so we're big advocates of the families being involved. By the time they get in our office, and even if it requires them requiring dialysis, many times these patients, we know their families, we know their loved ones, we know their siblings. And so we incorporate all of that to try to create a holistic atmosphere so that they can have health and wellness, particularly from a mental perspective.
Thank you so much. Thank you so much, Dr. Crenshaw. I'm going to pose this one for our resident genetic counselor. I'm so glad you're here, Barbara. Usually I'm answering this question, which I'm sure we'll have the same answer. But I love the question from Glenda Roberts. Can people get a genetic test without a referral from a doctor?
So the short answer is yes. Is it something that I advise? No. So yes, you could absolutely get a genetic test without a clinician being involved. There are companies on the internet that you can, have them send you a kit, and that kit will be a tube that you can put saliva in, and then you can send it back, and they will, do their testing and give you the results. The reason why I don't prefer that in the clinical realm is because when you get those test results back, now hopefully you'll want to do something about it, which means you're going to end up hopefully going to your clinician anyway to find out kind of what that next step is. And unfortunately, what we find sometimes is that the testing that was done was not something that fits the criteria that we look for when we do clinical genetic testing. And so sometimes that test has to be done again to confirm the findings that were done by that internet company, is one. And two, unfortunately, sometimes those companies, even if the results that they come back with are accurate, they're accurate for what they've included. And so therefore, sometimes they're not doing the full scope of testing that we would do for, in clinical space. And so let's say there's 5 different things we're looking for in the clinical space. Maybe that company only looks at 2 of them. So yeah, they're correct if they say those 2 are there, those 2 are absent, but they still haven't told you anything about the other 3. And so it just could be incomplete and lead to some confusion then, when more testing has to be ordered, or if we find, something different is going on. So but some people who are, very, very concerned about their data or something like that may choose to take that route because they feel maybe it's anonymous or, won't get back into their medical record. But again, if you get some results back that do have some clinical significance, we need that to be recorded, and we need that so that we can open up that avenue to be able to do better screenings, offer you different procedures, that type of thing. So but that being said, let me say, there's ancestry, genetic testing, those things are fine, right? Like things that don't necessarily have a direct clinical effect. There's a lot of great companies that will do that type of testing. But when it comes to health information, we really prefer for it to be connected in that clinical space.
Thank you so much. I will also say, to piggyback off of Barbara's answer, sometimes, especially in the last 2 years I've worked at Nephcure, we have patients who would like to have genetic testing, like the Albrights who've been great proponents of it, and it's benefited them. There are companies like Arcana as well as Natera who offer some of the kits, and then we do advise they take those to either a Nephcure specialist or a nephrologist they may already be established with, that has knowledge of genetic testing and is receptive of reading the results. But also on top of that, many of these genetic testing companies like Arcana as well as Natera and a few others offer free genetic testing free genetic counseling coupled with the results they get. Because one thing I ran into when I first got hired here was like people get genetic testing and they then would be like, oh, help me read the results. Well, I'm smart, but that's not my realm. And so it was like, I cannot help you do that. So we end up reaching out to this company, and gratefully and graciously, they provide genetic counselors that will interpret those for them. But I do think that you raise a great point, Barbara, in that realm. But if you are interested, oftentimes those genetic testing is free. If your insurance does not cover it, many of these companies do provide financial assistance programs that make them free. And you can also reach out to us at Nephcure, and we also have ways to advocate for you to ensure that you can get free genetic testing.
Yeah, then let me just piggyback. So, I would use Natera. Like that's a clinical laboratory that I would use if a patient came to me, and so those are definitely, great companies. And the other one you mentioned as well. They're great companies. Like you said, they often will also provide that genetic counseling assistance as well. And definitely that insurance help. If
For
people
sure.
don't have insurance, they usually have great patient like financial plans, things that can really assist. Sometimes they even are able to bring that cost down to zero or very, very low. So like you said, for free. So yeah, absolutely. Natera, excellent lab. There's just some other labs. I don't want to necessarily need them, but just other labs that will be out there. And they prey on people to, spend their money to get this information, and then it's not that accurate. But no, Natera is great. Yeah, that's great.
And Arcana and all the ones that are doing the good work and spreading the word and the good news, like Barbara Harrison is. Barbara, what is the benefit of the testing for the patient besides of being told you have CKD? I mean, I think maybe that's for Dr. Crenshaw in that realm. What is the benefit of the testing for patients besides being told they have CKD?
Again, another excellent question. I think probably one of the bigger reasons to be tested is for your genetic lineage. And what that means is that now this test, obviously, if it gives you a 20% chance that you may have underlying chronic kidney disease, what it does for the family is tremendous. And so if you're tested and if you have what's called the 2 high-risk allele variations, and this is information that is extraordinarily valuable to pass down to your kids and to your loved ones so that they can be aware. Listen, here's been the biggest issue for the last 30 years with kidney disease, particularly in African Americans. And I'll tell you the scenario that I usually see, and it's quite worrisome. When I see the 40-year-old gentleman who comes into my office and they're at stage 5 kidney disease, and they don't know how they got it. And guess what? These are men in their prime. They have hardworking jobs. Some of them are tremendously educated. They got kids. kids that are now about probably going to college, and lo and behold, they're devastated with the fact that they're about to have to go on dialysis due to end-stage kidney disease. Now, with the testing at hand, these 40-year-old individuals, particularly these Black individuals who are diagnosed at this stage, can you imagine if they were diagnosed perhaps 20 years prior because they knew that they had the high risk allele variations? And here's the wonderful aspect that I did not mention in our talk, was that not only now are we able to test, but there are medicines right now that are at stage 3 trial caliber, meaning that they're on the verge of being FDA approved to actually treat APOL1 gene expression, meaning that there are medicines now that they're going to perhaps be able to mitigate the gene expression of APOL1 pathology, ultimately leading to perhaps a cure. And what we expect and pray that within the next decade or so, there is this possibility that we can see a reduction up to 50% of African Americans on dialysis within the next decade. This is tremendous. And so part of this testing goes beyond just an individual being tested, but what is going to happen to the children and to the children's children and beyond.
Thank you. Thank you, Dr. Crenshaw. To piggyback off of that, if a person has the 2 high-risk variants, does that guarantee that they will have APOL1 mediated kidney disease?
That's
If
a good
not, what
question.
determines whether you will develop?
That's the answer is no. So you can have 2 high-risk allele variations. And again, here's the statistic. If you have 2 high-risk allele variations, there's a 20% chance that you will get chronic kidney disease as a result. So it's a very good question to understand that, yes, you can have 2 high-risk allele variants. What we're seeing, though, and particularly in the Western world, and while we're seeing this explosion of kidney disease in the Western world with the APOL1 high-risk allele variations, is that now it's being recognized that perhaps that there was called a 2-hit phenomenon, meaning that you have the gene expressions, those 2 high-risk allele variants, and then outside of that, there is some outside exposure that predisposes them to having severe kidney disease. And so what we're seeing in many different compartments in the country, for example, someone has the 2 high-risk allele variations. They don't necessarily have severe chronic kidney disease, but something tips them over, something like COVID-19 infection. And they get COVID-19 infection, and they already had inherently 2 high-risk allele variations. And now they go from having very mild disease to now ultimately having severe kidney disease requiring dialysis. This is what we're seeing. And so, yes, to answer your question, it does not mean because you have the 2 high-risk allele variations that you will develop chronic kidney disease. There's about a 20% chance of developing chronic kidney disease with the 2 high-risk allele variants.
Thank you. And a question for Barbara Harrison, which I think is very flattering, Barbara. The question is, I'm very excited. Well, it starts out saying, I'm very excited to see Ms. Harrison. How would my community find a Black genetic testing professional if they don't live near Howard? There needs to be like a matching tool, right, Barbara?
Yeah, there does need to be. So finding a Black genetic counselor might be a challenge. But I will have my information. Hopefully it'll be available after this. We do have a little network of us amongst ourselves. I do have to shout out our Find a Genetic Counselor tool. That's available through the National Society of Genetic Counselors. That's just a way to find a certified genetic counselor near you. But yeah, if you reach out to me, I can pop my email. I'm not sure.
What's your email? I'll put it in.
Oh, BW Harrison. So B as in Barbara, W as in water, and then HARRISON at howard.edu. And so I can figure out, kind of that's it. It's kind of figure out what town you're in and see if we can get you connected to someone. Because I do also know some Black genetic counselors that are available by telemedicine. And so that might be a resource as well.
Thank you so much, Barbara.
Yeah, but we're working on that. We know we need to get on that.
Hey, man, we do. We definitely do. I love the idea of a matching tool. Also, I have APOL1 genetic marker with CU1Q. Is that considered AMKD? I've missed some of the discussion. So that's one of the patients, Ms. Sharon Walker, who is joining us. And that's questions I think directed towards Dr. Crenshaw.
So you have a C1q variant and perhaps may have what's called C1q nephropathy at risk. To answer your question, you have to have the two high risk allele variations to be under the category of APOL1 APOL1 mediated kidney disease. And so that's something you will want to clarify. The C1q expression gives you another different type of disease, particularly at the glomerular level. It involves the same pathology in the glomerulus where you're getting damage to the glomerulus. APOL1 mediated kidney disease gives you classically focal segmental glomerulosclerosis. And C1q disease gives you a different type of glomerular disease. But yes, you want to clarify if you have the two high risk allele variations. That is very, very important.
Thank you. Thank you so much. I think we have, and Sharon also says thank you. Barbara, if I was attempting to bring genetic testing to my clinic, how would I go about that? Are you, the person who questioned it, asking that, Nick, do you mean like bringing genetic testing as far as like your testing kit, personal testing kit, or are you meaning that you want to bring that service to your clinic? And in the interim, while you answer that, so we can,
I'm sorry. No, I was saying like, and whether that question is coming from a provider, like a clinician,
right, that's
trying
what
to bring
I'm
into
trying to
their
clip.
clinic.
What is that a provider? I want to, so if they want to get more like community involvement or something like that,
Right.
or is it a test in general? If it's a test in general, I think Barbara will echo with me that you can look on different sites like Natera or Arcana, ones that or different websites like that that you can request genetic testing. We work a lot with Natera in the way that they are a service that we met them at ASN and many other national conventions, and they provided a lot of our patients with genetic testing. And most recently, our kind of introduction, I think, maybe through you, Dr. Crenshaw. So yeah, you can use sites like that really will help in you requesting a test. If also, you can always reach out to me and I can point you in the right direction to ensure that you have access to genetic testing, if that is you want genetic testing. And basically how that works for both providers, you basically request a kit, it gets mailed to your house. They both provide letters that serves more like templates. So you can take to your primary care physician and they can complete the test with you. And then you're provided with free genetic counseling following that test. We were asked to, thank you so much for a terrific panel. Thank you. Wonderful that you spent time with the Congressional Black Caucus today. What did you ask them to do? So I think the easy answer to that was that we were more so providing a service and wanted to spread awareness about RKD, especially APOL1, and also health equity. So we went with quite the mission. I feel like we went like my little Captain Planet group with us, me, Dr. Crenshaw, Barbara Harrison, Reverend Miles, our Nephcure family, Maurice, who champions our health equity division, as well as Sarah Prince, who's our manager of industry relations, and our operations manager, Aaron Parks. We went with the goal of spreading awareness about RKD, but particularly APOL1 and providing testing, urine testing, so that people detect for proteinuria in urine, which is an indicator sometimes of kidney abnormalities, and allowing them to have resources that we could follow up with them on, or they could follow up with us to receive more knowledge about APOL1, as well as general kidney disease and how it affects Black Americans, as it is so prevalent amongst us more than anyone else. So we really wanted to spread the word, get more testing done, ensure they have access to testing, as well as to spread the word about genetic testing, as Dr. Crenshaw did so graciously. So that was the purpose of being there. And also, we had a panel earlier as well in person, which was moderated by Reverend Miles, who champions community health equity as well as engagement at ENON. And what we did there was provide an in-person and live opportunity to be educated by Dr. Crenshaw, Barbara Harrison, here during Albright's personal journey with APOL1, as well as have Dr. Reverend Miles moderate, as well as provide some education about who Nephcure is and what we are about. So I think, oh, thank you, Margaret. It was very exciting. I think, and the recording for this will be posted on our site, on our socials in the next few days. I will ensure that. And if you need any assistance, if you need anything following this, anything you're interested in, and you want contact information for any resource, please feel free to go out to nephcure.org, as well as you can feel free. Oh, thank you, Brian, for posting that. As well as you can feel free to reach out to me personally thank you, Brittany. You can feel free to email me personally there, the mlucas@nephcure.org. Also, you will have my contact information will be sent to you following the conclusion of this webinar as well. So I want to say, oh, let me make sure we don't have another question before I think we have maybe. So let's end with this question. Dr. Crenshaw, broadly, when a Black person has protein in their urine, which types of kidney disease are they most at risk for?
That's an excellent question. So when you see protein in the kidney, or what we call proteinuria kidney disease, bear in mind that the two most common causes of kidney disease in the world, diabetes and hypertension, both have significant degrees of protein in the urine. And so when you see protein in the urine that is pathologic, you should not see that. Diabetes can cause that. High blood pressure can cause that. Conditions like lupus you can see protein in the urine. A classic condition, again, amongst African Americans where it is bona fide that you will see protein in the urine is the condition of focal segmental glomerulosclerosis. And this is where we get into APOL1 all again, because one of the hallmark manifestations of having APOL1 mediated kidney disease is having protein in the urine. And I would like to say this before we close, and this is very, very important. When you see your primary care doctor, it is imperative that if you want to know if you have any evidence of kidney disease, you have to ask the doctor to please check the urine for the presence of protein. And the reason why is because many providers don't do it. Why? Because as Reverend Miles alluded to, it's one of those silent manifestations. You don't see any evidence of kidney disease. You feel great. You don't have any problems. Your appetite is good, et cetera, But the problem is that there is evidence of protein in the urine. And when you see that, that is an early marker that there may be some inherent kidney disease. And I like to say that when you see that, at that point in time, it is a duty for your provider or your physician to begin working that up immensely to see not only if there's validated presence of kidney disease, but actually what is the type. And this is where I like to say you transition to a nephrologist perhaps, because a nephrologist will take this to the next level, which will include extensive blood testing, extensive urine assessments, and even to really diagnose the presence of kidney disease, it may actually require a biopsy of the kidney. This is how you really diagnose what type of kidney disease is through a biopsy. So yes, protein in urine is one of the hallmark manifestations of having evidence of kidney disease.
Thank you so much, Dr. Crenshaw. Thank you much. On that note, I want to thank, first of all of you panelists who contributed to today's success, as well as screening Dr. Crenshaw. Dr. Crenshaw is amazing. If you don't know, he's amazing. And I want to thank you, Dr. Crenshaw, for your contribution to the last few days as we were at the CBC for all the screening you've done. Barbara, thank you for opening my eyes a bit more for genetic counseling as well. So we'll probably have a follow-up conversation because I want to pick your brain more. Reverend Miles, thank you as always for being a great board member here at Nephcure and your continued support and contribution to our steps forward and expanding our health equity in particular. And Jordan, you have been like family to us. So of course, we thank you for everything that you and your family have done for Nephcure and partnering with us in spreading the word. Brian Johnson of Solivity, thanks for being a partner who continues to broadcast our message and allowing more people to have access to so much of the knowledge that we provide. We could not do it without you, Brian Johnson of Solidity. Thank you so much. And thank you all, and to all a good night.
All right. Good night, everyone.
Bye-bye.